So it's a common injury, as you know, we see it all the time when we do knee scopes, and obviously the grade of cartilage damage varies from minor scuffing to full thickness cartilage damage. Um, these are some statistics about how common it is. Cartilage is obviously very challenging to treat. I mean, it doesn't regenerate all that very well. It heals or it regenerates by fibrocartilage, which is good but not good enough sometimes. And historically, we know that there have been fewer attempts to kind of repair it. And we know about the layers, the superficial layer, the middle zone, and then the deep zone, about how the fibers are arranged and what their roles are. And then there's a calcified zone which separates the cartilage from the chondral bone. The superficial tangential layer is around 20%, the middle layer is around 60%, the deep layer is around 30%. Then there's the calcified cartilage, and then the cancellous bone. So depending on which joint it is, the thickness of the cartilage obviously varies. Chondrocyte is the kind of the cellular component of it, and then there's collagen. So the collagen is the non-living or the dead portion of the collagen, which obviously cannot regenerate on its own unless chondrocyte provides the molecules for it. It contains huge complex macromolecules, contains large positive and negative charged particles, and water. Chondrocyte is kind of enmeshed in the collagen, and it does not have much oxygen. It does not have much blood supply. So that's the challenge of kind of regenerating the cells, as opposed to other tissues in the body, like muscle, for example, or bone, for example. They have good blood supply. The cells, the osteoblasts, for example, can regenerate and produce new cells, new collagen, and all those things. But the chondrocytes cannot. The environment is not conducive for that. So yes, microfracture helps kind of bring in some blood supply, but if it's a large lesion, it is helpless. So even if there are chondrocytes. So the cartilage itself is not painful. So if you have a cartilage injury, sometimes the flaps can be, but as it gets deeper, then the subchondral bone is overloaded. So that can cause pain, and that's a cause of pain. This is sometimes asked in OIT or boards about which is the tensile surface of the collagen, and the proteoglycans are the compressile kind of biomechanical role in the cartilage. So there's significant forces based on these collagen and the proteoglycans that are required to fracture the cartilage, and it's as much as almost enough to fracture a femur. So what's the clinical implication if someone has a significant fall, say on the knee or the elbow? Yes, it can damage the cartilage, just a cartilaginous injury. We did speak out fluid, the water with its viscosity, and then there's matrix, which is elastic, that kind of gives us a bouncy kind of biomechanical properties. And the creep, which is defined by the rapid initial deformation followed by slow adjustments, and there's a stress relaxation. So it's truly a very efficient shock absorber based on how layers are arranged and the water and the proteoglycans content of it. So what happens during an injury? There's a disruption of the collagen framework. The proteoglycans expand, there's cartilage swelling, and there's proliferation of the stem cells, and they try to synthesize new matrix, from the new chondrocytes come in. Although again, we discussed there's a poor blood supply, so it's not as good, and the result is a fibrocartilage and not a true cartilage. So initially, they can have sudden onset of symptoms. I've seen in my practice true cartilaginous injuries. MRI looks near normal, consistent pain. When you go in, we look at we see a cartilage flap, a large flap of cartilage, which is sitting back where it belongs. So MRI looks normal, but when you put a probe, we can lift the whole cartilage flap, and obviously sometimes that's a source of pain. We remove that, and the patient does fine. So that's a true cartilaginous injury. Obviously, with any cartilage injury, you look at the mechanical alignment to get to make sure it's not advanced cartilage. injury. Utility of MRI if the X-rays are negative. So again, initial series had poor results, only 40% sensitivity. So it's difficult sometimes to note isolated cartilaginous injuries on MRI. Yes, if you do cartilage mapping, which we don't have, but it's a kind of advanced study, yes, you can see it. Or if it's a large cartilage kind of defect, then yes, you can look at it. So you'll see is that the gray area beyond that black line is the cartilage. So the black line is a subchondral bone. So don't confuse it with that. And then and this the small portion of that gray area missing is the cartilage defect. So let's talk a little bit about patellofemoral cartilage injuries. So chondromalacia is like one of the most common injury, kind of causes of pain, knee pain that we see here in our clinic in adolescent knees, and sometimes you can have a very mild thinning of the cartilage that you can see on the MRI. But more importantly, we classify cartilage defects into 4 types. These are the more common types that we talk about. Grade 1 is softening and swelling cartilage. It's kind of subjective, but you can compare it with adjacent cartilage. If it's softer, then it means it's grade 1 changes. Grade 2 is fibrillation, fissures, and clefts. So grade 1 and grade 2 are the most common we see in our practice because these are kids. We hopefully can catch them earlier before it goes into full thickness cartilage defects like in adults. And grade 3 is deep fissures to the level of subchondral bone. So it's pretty beat up, and 4 obviously subchondral bone. So we don't know like the natural history. We do know if it's a large lesion, it will progress to arthritis, but specifically how much of those, how many kind of progress is unknown. So what are the treatment options? We have to start with non-surgical management about NSAIDs and viscous supplementation, bracing. Unloaded bracing is important. It's underutilized. Weight loss. This is hard to bring up that topic sometimes with the child, obese child. Hey, all you need to do is lose weight and you'll be much better. How much of that works, we don't know. Cartilage injuries by definition is progressive. So and those things, if they don't work, then we have surgical options. Starting from just a little bit of debridement and lavage, known as chondroplasty, to something more aggressive like grafting. So we'll talk about what these techniques do. Basically, stem cells can turn into any of these cells that the body wants them to. They're very potent cells, and they kind of mold into the environment. So wherever they are brought into action, they'll just kind of metamorphose into the role that the body wants it to play. So as regards bone marrow stimulation, basically what we're doing is stimulating some stem cells in that area, and then it realizes, well, this is bone, this is cartilage around me, and I should kind of change into chondrocytes. So it does that. It's amazing how it heals. So microfracture, the concept is basically bone marrow stimulation or deep marrow stimulation. Historically, it was described as removing all the pseudocartilage, having great shoulders on the edges so that it doesn't the hematoma that forms doesn't kind of slip off, basically. And then there's the shouldered edges, and then basically insert all subchondral picks to drill or insert holes. I usually drill holes rather than using the chondral picks, because the later studies or the recent studies have shown smaller holes and deeper holes are better than larger holes and shallower holes. So there's the concept of nanofracture rather than microfracture, but the holes are smaller and they're deeper so that it can go into the subchondral bone and the vascular layer. And also there is some concern that if you have so many of these holes, it can actually cause subchondral fracture, a microfracture when the patient is walking and things like that, even after 6 weeks. A rat study that was done comparing these microfractures versus nanofracture, they noticed that if you do a microfracture with the awl, it disrupts the blood supply, in fact, and that's where the cartilage that's formed. Great. That said, the original studies that were done and the results that they had were very encouraging. 10 to 15 years out, the patients did great, and that's why it's still in vogue. A lot of surgeons will swear by this technique, and then they'll proposed this as the initial line of management. So the figure on the left is the subchondral bone exposed. The figure on the right is apparently a so-called success result. I don't think so. It is still, a very thin layer of cartilage. It might just wear off in a few years. So if you look at the literature very critically and follow up these patients for a longer period of time, microfracture doesn't hold up to its original promise. Obviously, the authors that describe this technique, they are very vocal in defending the technique, and they say that rest of the people don't get it, how it should be done, how it should be rightly done, and that's why they are blaming the method rather than the scientific data behind it. So Stedman and the group looked at these patients, and 7 years post-op, 80% of patients rated themselves improved. However, we don't know what the size of the defect was and what kind of activity level they had. So that's important as well. We do know the tissue that regenerates is fibrocartilage, which is type 1 collagen, not the type 2 collagen that is seen in true cartilage. 2 years post-operatively, biopsy showed only 11% of greater than 60% hyaline cartilage, but 69% predominantly fibrocartilage. So most of it is not good cartilage. And yes, may hold up for 5 years, maybe for 10 years, but what happens after is probably more degeneration. So one thing that is touted as very important after a microfracture is CPM and weight-bearing restriction. So patients should be non-weight bearing after microfracture. I still do non-weight bearing, and CPM. So this study kind of looked at it. It's a retrospective study, so it's not a level 1 study, but still, so I would say level 3. Where they looked at 2 groups, and they concluded that CPM and weight-bearing restrictions did not confer any improvement. So it's up to speculation whether we should kind of let them weight bear or not. So the next step up, if microfracture doesn't work, is OATS, or osteochondral autograft transfer. Basically what it does, it fills up the defects with small osteochondral plugs that we take from the non-weight bearing area. So different configurations can be done with it. So it doesn't have to be one single plug. In fact, because these plugs are very small, you have to kind of be imaginative and kind of use different sized plugs to fill in the defect. Let me tell you, this is very technically challenging, and I've done a few of these, and it's very hard to predict how you would end up having the cartilage slope. So the donor and the recipient side does not perfectly match. So trying to line that up is really challenging. And so basically, again, we take it from the non-weight bearing area, which is in the patellofemoral joint, on the lateral or the medial trochlea. It doesn't matter. Some prefer the medial side, some prefer the lateral side. So medial side is slightly better because you can push the patella on the lateral side. Through the lateral side, the IT band is in the way, and it's hard to put that big chisel down. The key point to remember is to make sure that you're perpendicular to the articular cartilage and not at a slope. And again, that's very hard to there are some markings on that, still it's not easy to predict. Then what you do is on the recipient side, you drill slightly under drill it, and then you push the plug in. It is a press fit. There are no screws or anything to fix it. One should be careful that we don't really hammer it hard, because the chondrocytes will then will kind of die. So you have to kind of be just gingerly put it without putting too much force on it. And then again, so you take it from donor side, recipient side, and then you push it in slowly. So if it's a small defect like that, yes, you can make it look perfect. But if it is a larger defect, and if you have 2 or 3 bone pulls, it's not a great look sometimes. So what are the results? The results of OATS are much better than microfracture. If you look through the literature, lot of patients had great functional outcome, and also long functional outcome. This surgeon he has described this technique. He's out of Europe, or I'm not sure, France or something, but or maybe Germany. But he has pioneered this technique. So he has, look at his series, it's like 800 mosaic plastics for over 10 years. That's a lot. And then he has some level 1 studies as well. So he has done the most work on this. But again, look at the picture on the right. There are like 12 plugs in that. I mean, it's like, I don't know what's going to happen with the patellofemoral space there, with no cartilage remaining. So he's very aggressive. And look at that large incision as well. So but he had great results. So amazing results. And these are patients with failed multiple surgeries and things like that. 83 patients underwent second look arthroscopy, and they're really good. This is, I think, patellofemoral arthritis, from the graft harvest, and then they found no kind of symptoms there, so that's good. Oates versus microfracture. This is a level 1 study, I think. Looked at 28 cases versus 29 microfracture cases. And then Oates had 96% good to excellent results. Microfracture 57%. So clearly the winner is Oates. So if you have the technical expertise and the ability to do it in younger patients, we do prefer to do this microfracture, and to just give them maybe a few years, and then microfracture will buy them a few years, but they have obviously a lot of more active years remaining. So we need to reconsider Oates more so in kids. And then so this is very important. Biopsy performed at 1 year, 100% of microfractured fibrocartilage, all the patients, as opposed to Oates had 100% hyaline cartilage. This is a great study, JBJS, and they looked at it, kind of. So obviously the pros are it's one-stage procedure. It's low cost, which means you don't need to kind of send that plugs anywhere. You don't need to get an allograft. But the main challenge here is technical expertise or know-how. So look at that picture in the bottom. You can see the plug is not flush, and it's like just at an angle, and that's unfortunately very common thing that I have noticed in practice as well, because it's hard to predict how it'll end up exactly how it'll end up on that side. Especially if there are multiple plugs, and if it's not seating flush, then it's maybe in fact a more of a eyewash surgery, which may not help. It's there's a limit to how many plugs you can obtain from the patellofemoral space. I would say the most I've done is 3. I think you can go up to 6, 3 from each side, but beyond that it is speculative whether it cause arthritis or not. But obviously there can be errors like these. The cartilage does not line up, and then it can cause lots of issues later. ACI is an important tool as well. It is basically a 2-stage procedure. We harvest the cartilage, send it for cultures, and then not cultures, but kind of they grow the cartilage and then they send it back. So you send it to this company, Genzyme, in Massachusetts, and they will send you back like almost 1 million or so chondrocytes from that small sample that you send them. Out of those 1 million, they say that 500,000 or so are viable, the rest die. But even those are really good. I mean, there's like a lot of chondrocytes in there. So even after you kind of implant them, if some of them do not survive, even then you have a lot of chondrocytes in that small area, which will help with regeneration. So these are the ideal indications. We don't want a kissing lesion, so we don't want corresponding lesions, otherwise we're going to do both. And then there's a size limit. Very large lesions, more than 4 centimeter squares, you kind of have to think about allograft. So these are of course ideal lesions, but that doesn't mean every candidate is like this. No previous surgery, so that is like very strange that they included it here, because most of the patients do have previous microfracture, things like that. But the reason they include it here is because there are a couple of studies that show if they have a previous microfracture, the results are inferior. So again, so that's why in my practice, if I think they need some kind of cartilage procedure, unless it's in a non-weight-bearing joint, like say elbow, or a very small lesion in ankle, for example, they do okay with microfracture. Then I would do it in a knee. I tend to do oats if needed, rather than microfracture. So what is ACI? Basically, you kind of put a lot of chondrocytes, because as we discussed in our basic science slides, that there are not many chondrocytes. The blood supply is not great, so if there's a cartilage lesion, we want to supply more chondrocytes in that area. And basically, from the interchondral notch, you take a sliver of cartilage, and then you send it for culture. You should be prepared for it. So what you need to have is a kind of a special container in your freezer, which the company provides. So you can't just go in the knee and decide, oh, I want to do a ACI for this patient. You have to have that container in your freezer, because that has to be shipped overnight to the company. And then basically the culture, and then they obviously is proprietary, so we don't know exactly how they do it, but they have that medium for doing it. And then the second stage is in 6 weeks to 18 months. They'll hold it up for you for 18 months if you have some issues scheduling the surgery. But after that, they kind of discard it. Then you do an open approach. You kind of create a good recipient site, and then take a layer of periosteum. That was how it was described, but these days we have collagen scaffolds that has been approved by FDA. So we have a lot of these artificial collagen membranes. You can stitch that up, so you don't need to harvest the periosteum from the proximal tibia, which requires a very long incision. So you don't have to do that. All you have to do is just take that artificial membrane, put it out there, stitch it up first, leave a small gap, and then inject chondrocytes through that gap. Make sure it's watertight. So all around, so just the number of Vicryl stitches all around, basically to make sure these are 4 or 5-0 proline or Vicryl, very delicate stitches. Obviously, you don't want the stitches to be bulky and interfere with cartilage kind of friction. So the results are pretty good of ACI as well. The only problem I see incorporating that in my practice out here is the insurance kind of thing. It's very expensive. It's I think around 7,000-8,000 for just that chondrocytes, and obviously the insurance companies may not pay. Some of them pay, some of them don't. Most of them don't pay for it. So it's hard for patients to have them pay out of pocket, especially um, um, with changing scenario of insurance and all those things. They don't want to pay. But most of the studies have shown great results. And okay, so if you compare the two main techniques, ACI versus oats, um, most of them are kind of equivalent. They are comparable. They're good. If you look at centers that do more ACIs, they obviously have slightly better results. But if you look at patients, surgeons do oats more than ACIs, and it's skewed towards oats. But there are several of these studies that I've included here that show that ACI does as good as oats. The only thing, it's expensive. It's a two-stage surgery, and but I would say it's slightly less technically demanding than oats, because for oats you have to have this perfectly placed plugs. For ACI, all you need to do is get those chondrocytes, take a collagen membrane, stitch it up, make an open incision, and just inject it. So technically, it's much more straightforward. There's no that ACI and oats are both better than microfracture for long-term outcomes, for histology is better, and patients are more satisfied with. Yeah, this is an important slide, so I didn't want to skip this one. But this is kind of the bottom line from this talk is the size of the lesion and also demand of the patient. So by definition, most of our patients here are young, kind of athletes or school kids who are very active. So they're high demand. And then you look at the size of the lesion. If it's really small, 1 to 2 centimeters, yes, microfracture is the way to go. But if it's slightly bigger, 2 to 3 centimeters, then look at the high demand category. The options are osteochondral, autograft versus ACI. So that or allograft if it's a large lesion, but that's basically microfracture is kind of out when it's a large lesion, and I agree with that recommendation. That said, again, practically, if you see, most of us are more comfortable doing microfracture. It's quick, it's easy, you won't be faulted for it. And if you can always say, well, if this doesn't work, I'll think of doing ACI or OATS. But there is evidence in the literature that the second time surgery for OATS is not as successful as first time. So truly, I think if you're familiar with that technique, you should offer patients. Patellofemoral joint is a little more complex. You have to include Fulkerson's osteotomy just to offload it. That's when you come to allografts is also a good technique, and I like this technique because it is straightforward. I've done a few of these now, and it's a large plug, so there's less room for error as opposed to the small plugs where the cartilage may not be perpendicular. And then basically those plugs and shove it in. Most of the results are very good. There's this slide kind of brings up a very important topic about the cartilage. I mean, can that cartilage survive? So we need fresh, frozen, or at least refrigerated, which is at least 14 days. It requires for extensive microencerological testing, and then the problem is the chondrocytes begin to kind of die, and then so what we prefer is fresh, frozen. The donor has to be screened very, very well to make sure there's no infection, and that's the best way to go. So these grafts come with a time frame. I think I've done 2 or 3, and then they give you like a 7-day notice, and it's hard to kind of schedule surgery within 8 days. It's in call the patient, say, your surgery is going to be this Saturday, for example. It's like almost like a transplant, but we have 7 to 8 days, sorry, depending on the graft and the company. But this in itself is kind of a talk or something, because it's important how the cartilage is harvested. I mean, the graft is harvested, and what are they doing? There are different ways to kind of do it. It's also a biocleanse method, which there is no kind of sterilization for the graft, and it's just they dip it basically in different antibiotics, and they have found that it is extremely low rate of any infection. So that's another way to do it. It's basically dip the graft in antibiotics, as simple as that. Different antibiotics, and it's supposed to be pretty good. So again, the results for excuse me, allograft is also great. Most of the have succeeded. These are the latest kind of collagen gels, sponges that you get. There are different kind of chondrocyte products. There's something known as juvenile chondrocytes that's in the market. It's slightly less expensive than ACI, where basically, sad as it may sound, the chondrocytes are from young donors. So it's like kids less than 13 years of age. They harvest their cartilage, and then they have this chondrocyte in packs, and then you can open up those chondrocytes, and it's a one-stage procedure. The initial results are very, very encouraging. So that's good as well. So. But I guess of all sports medicine procedures, cartilage regeneration, cartilage injuries are definitely more challenging than ligamentous injuries and other injuries. Um, you know, but 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 we do have some well tested techniques. Some are a little more challenging technically than others. Some are more expensive.